First of all, I would like to thank Christine and the organizer for inviting me to this meeting. And this is the front, actually, entrance of my hospital. And I must say, I don't have a slide to show you where Birmingham is and how beautiful it is. I didn't, in fact, it wasn't intentional. I actually remembered I wanted to invite you personally. So please do actually, organize your next meeting in Birmingham. So I must also point out we have more canal system than Amsterdam and Venice. So with that, I think. Sorry. So I must, because when someone talk about enzyme replacement treatment, there are two products. This is my disclosure. I have, I think, both actually Genzyme and Shire have supported me developing service and also giving me unrestricted grant. So my outline will be, I want to actually take you to the real world because, every day people are, we are all unique by our own nature, and some people do respond to treatment and not others. So, and as a clinician and as a patient, what we see in the statistics may not reflect what actually we feel in real life. Then I will take you through, in fact, most of the actually findings have been. Are you able to hear me from this distance? Okay. I will talk you through about randomized controlled trial. This is essentially the gold standard to actually show a treatment work when it is fully blinded, randomized, and controlled with placebo. Then in addition to that, there is what we call it observational studies. These are the study, you don't have hypothesis, but you gather data as part of a daily practice to see whether treatment is working. And that's not as strong as the randomized controlled trial, but it still answers some of the questions. And then I'll try to summarize and see where actually, what's the next step. So I'll start with a patient of mine who is a 60-year-old gentleman with Fabry disease. In fact, he has Fabry signs and symptoms since he was in late 30s, and the diagnosis was made actually relatively late. So I saw him recently, came in with generalized weakness and malaise. He had abdominal pain of 2 weeks duration, localized mainly on the right side. He had previous history of a small bowel perforation. On further actually questioning, he lost weight, about 10 kilograms in the last few months. He passed a small volume of stool and urine. He wasn't vomiting. On examination, he has high temperature. His blood pressure was very low. He had distended abdomen and tender, and inflammatory markers as measured by CRP was very high. I think clearly the patient actually from the history and examination, he seems to have what we call it acute abdomen, which requires surgical intervention. This is this CT scan of the abdomen. Take my word, there are free actually fluid suggesting there is a perforation, and there are a lot of small actually pouch of small intestine, what we call it diverticulosis. It's relatively common in a large bowel, but it's very rare in a small bowel. It's very unusual. And so the patient underwent surgery, and they removed about 20 centimeters of his small bowel, and this is the histology result. So they joined the two end, the patient is doing well. When we looked at the histology result, in fact, you could see storage materials, especially in the smooth muscle of the small bowel. And further, actually, A larger magnification clearly shows the storage materials, as you could see from the arrow. And further staining with toluidine blue, you could see dark blue black granules indicating a stored material. And then we took actually electron microscopic study. You could see inclusion bodies, and in fact, there's a good picture of what we call it zebra bodies. The reason I'm showing you this slide, not just that this complication is unique, but this patient has been on enzyme replacement treatment for more than 5.5 years, and we still see storage materials. I think that's a bit disappointing. And in terms of the progression of the kidney function of this gentleman, this is a graph I picked actually from our electronic patient recording. So I'll show you. So actually the y-axis is the creatinine. The creatinine is really the waste product. So it's the higher it is the bad the kidney function is. I think nowadays we do measure what we call it GFR, the filtration rate of the kidney. So he started enzyme replacement treatment around 2007, and he continued to progress. In fact, he required dialysis at that stage, despite being on enzyme replacement treatment. So this patient started on Fabrazyme. During the shortage, he was switched to Repligal. So we have actually the test of the two enzymes. As you could see in this case, really it didn't halt the progression of the disease. And he had been on transplant list, but unfortunately, because of his other comorbidities, after long waiting, they felt he's not suitable for transplant. What about other organs? In terms of his heart, in fact, that was the first thing which actually brought Fabry into diagnosis, into attention. So he had enlarged heart in 2001. That was before he started enzyme replacement treatment. He had complete heart block requiring a pacemaker insertion in 2009. He had heart attack in 2010. He had heart failure and requiring numerous admission in the last 12 months. That is in addition to the most recent one. So having gone through both the kidney requiring dialysis, the heart having all this problem, I think after extensive discussion with the patient and family, we've agreed to say, well, at this point, enzyme replacement treatment is not working. It's not an easy decision to make, but I think it's sometimes there are a point where we have to actually face this difficult question. But that doesn't mean the care of the patient stop here. The patient will still continue to have the same care what we would have given him when he was on enzyme replacement treatment. In fact, he's happy with that arrangement as it is. The second case, yes?
So in that case, were you able to go back and look at if the patient had regular antibody testing or if there were other medications that may have inhibited the effectiveness of treatment? And is this a case where you would have said this dose is obviously not working? Would you increase the dose? Were you able to go back and figure out any other reasons for the ERT not working?
I think
I know it's not definitive, but anything that might lead to a guess about.
in this case, what I haven't mentioned, the patient had all the other cares required. Patient with kidney problem and heart problem, so he has all the treatment required. With regard to antibodies, I must confess, we have done the test. Part of it we have difficulty, which I would mention later on in terms of accessing it. In fact, one of the issues we discussed yesterday in the professional meeting where we could actually address this. We haven't looked at it yet, but that might also one area which may have explained. So the second case is a similar patient. Diagnosis was made when he was in late 20s. This is the graph of his kidney function test. And he was fortunate enough to be enrolled in the initial Fabrazyme study in Manchester. And he started enzyme replacement treatment almost 11 years ago. And this is his kidney function following actually 6 years on enzyme replacement treatment, requiring dialysis in between. And finally, he had a transplant around mid 2007. As you could see, after transplant, the kidney function really came down far better than what it was. I think from this perspective, when you see it, yes, the progression wasn't halted, but there is other way of also treating it in addition to actually enzyme replacement, in this case transplant, which seems to, as you could see, it has solved relatively his kidney problem. But what happened with other organs? Despite being on enzyme, again, it's the same story. Started on Fabrazyme and switched to Repligal during the shortage. Then the heart became a problem. He has developed all these conditions, and one would also wonder what thyroid eye disease to do here. But in fact, he had very fast, actually, atrial fibrillation. He was trying to have a shock treatment, didn't respond. He was given amiodarone, and a drug which controlled rhythm, but that is a side effect also. It affects actually the thyroid gland. So I shall stop here. Yes, please.
I just had a quick question with regards to the patient. Did you assess the baseline proteinuria or glomerulosclerosis, because that impacts potential progression of?
Yeah, that's a good question. The first patient, actually, his proteinuria was in excess of 1 gram per 24 hours. And in fact, at that point, when he had a biopsy, he has extensive sclerosis.
So that may impact the
That's correct.
enzyme.
Yeah.
Okay.
So let me talk you through now the clinical trials. I think we've had to clearly actually discuss this. The phase 3 is the important one. It's what we call this landmark study. This is really a very good study, and they compared relatively severely, or what we call it classical Fabry patient, predominantly men. 58 of them, split them into two groups, enzyme replacement arm and the placebo group. And the primary outcome was reduction of storage materials in the kidney blood vessels, so what we call it interstitial capillaries. Because the reason I'm pointing this out, in the kidney there are a lot of areas where we actually can look at the storage. Some areas are easily accessible to actually clearance for enzyme. Others, for example, like podocyte. In fact, recently Camilla from Bergen showed us that actually require a higher dose and a longer period to actually clear. So the finding was impressive. 20 out of 29, 69% of them actually not just only reduction, it was complete clearance of the storage material, and none in the placebo group. That is really a fantastic actually finding. And the secondary outcome, they looked at also storage materials in other organs, and that itself was very good. For example, in plasma, the clearance, it actually within 14 weeks, it normalized, but none in actually placebo group. There was some telltale in that story. The kidney function did not significantly change despite this impressive actually clearance of a storage material. And the quality of life and level of pain, in fact, both the placebo group and the actively treated group, there was no significant change. So storage is one thing. That is also important, what the consequence of it and how that will improve. They went on and do phase 4 trial. Again, this is a very good actually trial. In fact, one of the strongest evidence we have in terms of enzyme replacement treatment. In this case, rather than the storage materials, they actually looked what is the end product of it. What actually said, well, how many of these patients, if actually with treatment, will prevent kidney failure. There is some area, because they looked at the percentage of reduction of the kidney function, not rather than how many of them required dialysis, how many went to transplant. Again, it looked the same for cardiac and a stroke event, and they followed them between 18 months to 35 months, and the graph is like this, because fabry is also a challenge for study because it's a very heterogeneous and slowly progressive condition. So the event rate was a third of the patient had an event in both group. As you could see here, there was 14 out of 51 because the way randomization was 2 in the treatment arm, 1 in placebo arm, and 13 out of 31. This is equivalent to 27. This is 27. This one, the placebo arm, is about 42% in terms of event. When you look at the split, it is the renal function took most of actually the event, but that event is not really what we call it hardcore event. It's a 33% reduction. It's not requiring transplant or dialysis, and the cardiac event is more or less similar. So this is a statistical value, as you could see. It's not impressive, but when they actually looked at those patients, 74 of them who they actually stick to the protocol, there was some significant difference.
Could you go back 2 slides? The one about quality of life and pain. I think one more. You had a slide that talked about quality of life and pain. Yeah. So I'd like to say something. So one of the things that we learned in the unfortunate shortage was that, so if you're a person with Fabry disease, I think there's a huge mental component to it. And so even with a person like me who has very definite clinical evidence of improvement after 10 years of treatment in going from chronic kidney disease stage 3 back to stage 1, and significant reduction in the thickness of the left ventricle wall and in the volume of the heart, I don't always feel better. So the subjective data, like quality of life and pain, when you ask a Fabry patient how they feel or how they're doing, one of the things we learned during the shortage was that people don't remember what they felt like a year ago or 2 years ago or 3. So if you ask a lot of people, they say, I really don't feel any differently, even though I'm clinically better. And so I think the subjective data is really, really dangerous to use in terms of no significant improvement in pain or quality of life. Most of the time, our memory of pain and quality of life isn't that good to be able to really tell you if we feel that much better or how we're doing, how our quality of life is. So we heard from a lot of people when the shortage occurred, and when they got back on treatment, I didn't realize how much better I'd gotten. And there was many, many people, not just a few. So we improve and don't even realize it in a lot of ways because we still feel bad. We still have GI problems. Life's not perfect, but it's better. And we just forget what it was like when it was worse.
I mean, I fully agree.
In fact, it is the reason why you should take the quality of life questionnaire relating to the last months, and then after 6 months you take another one, and after 1 month.
Sure.
And later you can compare.
I think it's helpful. It's just because it's so subjective. What I said was a pain level 4 2 months ago. I may say it's a 2. I may still say it's a 4, but it has changed based on my perspective of my overall in my own mind. It's just not good data. I mean, it's useful in general, but not in determining whether ERT is working.
No, I fully agree. In fact, there may well be also difference if whether patient actually report that outcome themselves or whether we actually help them, filling that form too. Yeah, I fully agree with that. Then going back to the second enzyme, agalsidase alpha, they did the same randomized placebo-controlled trial involving single center, 26 adult male with neuropathic pain. So the primary endpoint was actually how the pain improved. I think essentially there was a significant improvement. Almost all of the patients actually in the active arm show significant improvement. And they also look at a secondary endpoint, the storage materials in plasma. There was 50% decrease and then 30% in the urine. So I think from that point, it was actually at least met the primary endpoint, and we know it also helped clearance. They did look at the proteinuria, which is a marker of leaking kidney, and the cardiac conduction system. There was no significant change. And then they had the long-term open-label extension, and those actually patients in placebo arm were switched to the active arm. There was significant improvement in terms of pain, but there is no further additional reduction beyond the 6 months for those who are already on treatment. And they also noticed there is some difference in terms of temperature sensation. This actually, they went on further doing, in fact, this is from Atul group, Derelin, did randomized controlled trial of 15 patients split into 2 groups. In fact, they showed with using aglycidase alpha, the left ventricular mass decreased. In fact, it may actually help not just slowing down, it actually may help reversing the process. And clearly they did also see the storage materials. And another group looked at the exercise tolerance test. They also felt there is a significant difference, people who are on enzyme replacement treatment. Again, in fact, it's good to know many of the people who contributed on for enzyme replacement treatment, they are in this room. So if I misrepresent your finding, please do let me know. So when this is actually looking, again, the Shire product following the outcome actually registry, really more than 180 patients in each group. In fact, you could see people who have left ventricular hypertrophy, actually there's significant improvement when they look at the mass. In fact, it shows there is not just slowing the process, it may actually help regressing the process or reversing it. At the same, also when they look at the kidney function, the rate of loss was actually significantly lower. You could see also there is a sex difference. I think the females seems to do better than male. Again, with the quality of life and pain, we saw significant improvement all the way through the 5-year follow-up. Effect on hearing function, again, it's the same from Atul group. They did randomized controlled trial. Initially it was 6 months enrollment. I believe there was no difference, but further extension of 18 to 13 months, they showed significant difference. The kidney, they looked actually in this study 3 randomized double-blind controlled trials. This is their findings. So the group actually, many of them, this is the cutoff point. Normally after the age of 40, every one of us, irrespective of whether we have fabry or not, we lose actually our kidney filtration capacity, roughly 1 milliliter per minute per 1.73 square meter area. So this is the cutoff point. But for Fabry, they did use this cutoff point to show people, what we call them, rapidly progressing. And as I think, as you could see, there are also other markers here. The amount of protein excretion, in fact, is exactly the same with the 2 cases I presented early on, why they actually went on requiring dialysis despite being on enzyme replacement treatment. They saw clear difference. And I think essentially there was a significant improvement, reducing the rate of actually renal function loss. This is a busy slide, don't worry about it. This is essentially the summary of what we've discussed actually, the randomized controlled trial. But I just want to highlight you the various studies shown. There are 20 different actually criteria people can look for a Fabry. In fact, it could be more than that. And most of the study, there is consistency in this group. This is really a clearance of storage materials. And there is actually the story is the same everywhere, repeated if they were tested. But the other thing also which makes actually comparison difficult is because some study look at the primary endpoint, one aspect of it, others a different aspect of it. That actually makes it difficult, if we want to compare the two enzymes. This is the observational plus the summary. So behind this busy slide, I usually have the summary, so don't worry about it. So this is actually the people and the years the papers were published. So I grouped them into different organs in this case, and the type of drugs involved in the study, how it was designed, and the total number of the study, because the more patients you have in any study would be the better in terms of assessing the outcome, and the number of study in each arm, whether it's controlled or it's just treatment arm, the age range, gender, and duration of the study. And these are the primary or the main objective of the study, what they looked at. This is the level of evidence. The level of evidence, according to medical practice, the lower it's the better. Okay, I'm aware of that. So I'll move on to the summary of this. So there's clearly there's a good evidence and very convincing treatment is safe and well tolerated. Clearance from endothelial deposits is it works very well. In fact, it clears completely in many parts of the kidney, and we can reduce the rate of decline. We could stabilize it. Patients on hemodialysis could also have enzyme replacement treatment. What we don't know, we don't have hard endpoint, what we've discussed, preventing dialysis, preventing actually transplant. And randomized controlled trials, many of them are small. And also we don't know whether there are people who respond to treatment, and there is a point of no return. So if there is a scar in, say, the heart or the kidney, whether the treatment will benefit at all. Again, the same as this is looking at the heart, you could just see a lot of paperwork, actually, a lot of research. Most of them are observational. In fact, the last two were discussed with Atul, the most recent one. So the summary of it is there's a good evidence to say storage materials could be cleared from the heart, and the rate of increase, because the natural progression will be enlarged or thickening of the heart, could be slowed down, stabilized. In some circumstances, it could actually be reversed. But what we don't know, whether it improves the function of the kidney, the heart. We don't know if the exercise tolerance will improve. Certainly, we don't have evidence to say it will prevent sudden death, it would prevent rhythm disturbance, or prevent heart attack. Again, the same, this is for looking at intestinal functions, hearings, and skin, angiokeratoma, and sweat. This is the CNS and peripheral nerve. I think Atul showed us good slides. So really the summary is good evidence to say intestinal pain and symptoms will improve. Pain in the peripheral will also improve. The quality of life, I think there is more evidence emerging, it will have an impact. But what we don't know, or have very little evidence, whether if the white matter change we see in the actually MRI will improve, and we don't even know what that means actually, if whether the hearing will improve with enzyme replacement treatment, and whether the angiokeratoma and sweat or intolerance will improve. So to just summarize, I will summarize with my wish list, what really we would like to see, or what are the questions really require, because as a group you are powerful to actually influence policy, research, both actually the scientists and the fund holders, and in fact also industry too. So really there are a lot of, it's 12 years since we have our first actually two enzymes. It is, it's a big step forward for a rare disease to have disease-specific treatment. But we can't just rely on, say, okay, we've achieved that. I think we need more. Our patient, as I showed you, the two cases, we need more treatment, which actually work better. So, 12 years on, we don't even know, we have got two products. In terms of the structure, they are all more or less identical. But in terms of dose, one is 5 times than the others. And we don't even know which actually dose is the right dose. And we need actually, clearing the storage materials as a patient and clinicians, we wouldn't know it. You don't feel it either. But really what you would know when the kidney stop working, you know when your heart rhythm is not working. We want to see whether actually this treatment is preventing. We talked about before actually every major irreversible change occurs, we need to start actually treatment. I know Umar might tell us about the young actually, I think below the age of 25, there is a study going on. But as adult physicians, most of the time what I see patients, they are actually in their 30s or 40s. So we want to know, because the national criteria of most countries, it doesn't allow us to treat everyone. So we have patients who have Fabry disease with symptoms, don't meet the treatment criteria. So we can actually do randomized, double-blind, placebo-controlled trial in this group. So really, we need to push industry to actually say, well, we want early treatment, but we want also evidence for it. So if we have the evidence, it's easy actually to convince patients to take treatment. It's easy to convince also the funding organization or the commissioners to pay for it. We also don't know what the impact of Jerry raised a good question, whether if the patient have antibodies. Antibodies are essentially our immune system learn whatever actually a protein in our body, whether it is self or it's foreign body. Because many of actually patients with Fabry, severely affected people, they don't actually have enzymes. So the body actually recognize when artificially made enzyme is infused, recognize that as a foreign body and try to actually neutralize that effect. So we don't actually know whether that will impact on the function of the enzyme. We need to understand that better. A patient with Fabry-related actually kidney disease behave the same as patients with diabetes. In diabetes, we know if we control the glucose below 6.5, we'll minimize actually the risk of progression. We want to have the same biomarkers. In fact, yesterday, Roberto was discussing lyso-Gb3 may act in the same way. So really, we want to know how low we need to bring that lyso-Gb3 and with what method to prevent the kidney progression. And I think it would be good to also see the combination. I'm really excited to see the combination of chaperone and enzyme replacement treatment. I said current providers doesn't exclude my friendly colleagues here, but the reason I raise this one, we are struggling currently paying one treatment alone. Really, we need a way where industry work together and that cost could be absorbed, so we could have actually the option to offer, because we could see probably the antibody response might be modulated. And we saw the graph from Atul, the enzyme activity will be enhanced. And we also saw our patients in some circumstances, they don't do very well. So I think this is probably a future, but with the current pressure and cost, we have to have a mechanism how this could be absorbed. So I'll stop here, and thank you very much for your attention.